Imagine a ferocious growling wolf running toward you. Your body instantly goes on high alert. This happens because our body has an alarm system, the stress response system that keeps us safe in dangerous situations. Under fear, our body reacts in different ways. We may want to run away, which we call flight, to confront, which we call fight, or to remain still, which we call freeze. This response is regulated by the hormone cortisol. A small amount of cortisol is necessary for safety. However, prolonged high levels can short-circuit this alarm system, shrinking the key regions of the brain. Children living in conflict zones face constant stress due to surrounding violence. This disrupts the brain development, including brainstem, which regulates essential physical functions like sleep, appetite, temperature, and heart rate. As a result, their sleep and appetite become dysregulated, leading to chronic fatigue and malnutrition. The amygdala, the brain's fear and anxiety center, becomes hyperactive, making the child constantly nervous and unable to relax, even in safe situations. The hippocampus, responsible for learning and memory, shrinks, causing difficulties in concentration and recall. The prefrontal cortex, which governs planning, decision-making, and emotional regulation, is also affected. This results in poor focus, impulsive decision-making, and difficulty managing emotions, making the child prone to aggression and struggles in planning for the future. Moreover, factors like malnutrition, exposure to violence, abuse, and social discrimination further exacerbate stress, negatively impacting their mental development and overall health. Trauma even affects our genes. Imagine a library containing all the critical information about our functioning. Each book is a gene, and every page is a DNA sequence. Epigenetics reveals that our environment leaves chemical marks on these pages, determining how our genes are expressed. A scientific study on mice found that limited parental care during childhood developed a specific epigenetic mark on their DNA, making subsequent generations more sensitive to stress. Even one adverse childhood experience can leave complex dark marks on significant chapters, potentially harming countless generations. However, the remarkable discovery was that the epigenetic changes caused by receiving parental love reduce stress sensitivity in future generations. The human brain has remarkable plasticity. Through support, therapy, learning new skills, and positive relationships, the brain can rewrite those negative marks on DNA and form new neural pathways and connections. Understanding the neurobiology of trauma helps us provide better support to affected children. By promoting positive experiences, we can foster healing and resilience, ensuring a brighter future for the next generation. There's no magic wand to change the world, but when we pause to reflect, unlearn harmful patterns, and relearn with empathy and intention, we spark ripples of change that can build the safety, trust, and love every child deserves. Healing is possible.
So, a warm welcome, Tanuja. Over to you. Thank you.
Thank you so much, Kavita. A very warm welcome and good afternoon to all the participants who've joined here today. Thank you to ICN as well as Miracle Foundation for having us here today and really finding time to sort of bring to light a very important domain that within the child protection space, we all are looking at engaging more in. So I'm just going to take a few minutes to talk a little bit about the scope of mental health within the child protection space. Now, roughly, when we look at sort of India and the number of children who are in need of care and protection, and if it just 5 and our big data tells us that there are about 150 million children which came in 2002. Both of those policies and laws prioritize or indicate to prioritize family-based alternative care over caring for children within institutions. So therefore, foster care as well as kinship care become very critical modalities in terms of responding to and caring for children. Regardless of this, unfortunately, less than 1% of children within the entire protection system are in formal foster care. And what we see also around the country is that institutional care is something that remains the default go-to to sort of respond to the needs of children who are in need of care and protection. Now, when we sort of look at India is, of course, we know that India is a signatory to the UNCRC, as well as the UN guidelines for alternative care for children, which came in 2013. And both of those, again, indicate that growing up in a family environment is something which is every child's right. And it's important to recognize that the policy as well as the laws of our country again and again focus on for children, the best place to grow up is their families. When we look at the national policy for children, they also sort of mandate strengthening of kinship as well as family care system or family based alternative care systems, which can respond to or care for children in a better way. Now, when we look at mental health within this space of child protection, what we also know from research is that when children grow up in institutional care, they are 2 to 3 times at a higher risk of depression, anxiety, attachment issues, or developmental delays as compared to those who grow up in family environments. And there's a lot of data that shows the benefits for children when they, in terms of their own growth and in terms of their own building healthier attachments and their mental health for when they are growing up in family environment, which is predictable and which is stable. We in India we have the National Mental Health Care Act 2017 as well as the National Mental Health Policy, both of which again recognize that it is the children's right to be able to have access to acceptable forms of mental health services. However, what we do see is that mental health is not fully systematically integrated within all levels of child protection system. And at the same time, what we also see is a bit of gap in terms of being able to offer care from a trauma-informed lens, or even sometimes care or support options available for caregivers. The focus is on offering mental health support to the child, but caregivers or foster parents who are sort of caring for children are often missed out within this space. So without such an approach, what we also risk then is that alternative care arrangement could become a way of placing child in an alternative space, but rather than a pathway for children to heal and for children to be able to take care of their well-being and to be able to thrive. So learnings that we have had from some of the work that we have done as UNICEF within the district of Jalna with the model of setting up kinship care support models. Now, Jalna is typically a district which is a drought-prone region. And there what we see is a trend of seasonal migration, which happens for a long period of time, whereby the entire family migrates for 6 months, for a period of 6 months. Just give me a moment. I'm just getting a message that my network is unstable. Okay. I hope this will be relatively better. Yeah. So just going back to a few, what I was talking about, some of our learnings from the work and interventions that we have built within this space. What we have tried to do is that when families migrate for a period of 6 months, the children migrate with them. And therefore, not only are children exposed to a lot of safety violations and risks for when they are at the destination site for sugarcane cutting along with the family or to work in brick kilns, what also does happen is that their education is interrupted, and they're further susceptible to having poor well-being and mental health challenges like early marriage or early pregnancy become the risks that children face. What we did do in Jalna was set up a system of kinship care, whereby grandparents who stay in the village would take care of the children and the parents would go off to migrate. And with this, one of the critical thing was that the backbone of the entire program for us was a youth volunteer known as Balmitra, or translated as friend of the child, whereby this Balmitra not only helps in identifying who are the families who are potentially likely to migrate and where children could face risks and could be in need of alternative care and family-based care. They help facilitate the kinship and family-based care arrangements and run an after-school program known as Manacha Katta, again translated as the Mind's Corner in Marathi. What the Balmitra does through this program is to engage in various activities, sessions, discussions with children to offer social, emotional learning activities so that children's well-being and mental health is maintained, but also maybe sometimes as required to offer specific dedicated support to certain families and children, such as linkages to social welfare schemes or responding to structural challenges in collaboration with CWCs, DCPUs, and so on. Now, some of the key learnings that we have had from a model like this, which what it does is facilitates informal kinship care system, whereby mental health and psychosocial support interventions are layered on to the existing work. What we see was that kinship care, whereby grandparents are the ones who are caring for the child, is a much more acceptable form of alternative care, because there is a trust, and the child is able to continue living within their own communities and continue to living in their own families. What we also saw is that mental health experiences of children as well as families is not a linear journey. But mental health experiences are not just an outcome of what the child feels inside their mind, but an outcome of what is happening outside of the child, which is the child's lived realities or the family's lived realities. So, therefore, making mental health intersectional and very closely linked to the problems of living, like unemployment, like financial stress, and many more others. What we also saw is that along with children, caregivers also needed equal amount of support and handholding to be able to look after the children themselves. And sometimes it is emanating from life's problem of financial stress. Sometimes it is lack of guidance. Sometimes it's parenting support, or even what we see in foster care work. Parents themselves need a network of peers or individuals that they can rely on for their own mental health care. Now, what we saw over here is that mental health, therefore, can move beyond just symptom redressal, but rather focus on creating, supporting well-being of children, which can teach them learning skills, emotional skills to be able to regulate themselves, to be able to form healthier relationships, and at the same time, by doing so, preventing other challenges which could come up in the future, like early marriage or child labor or unsafe migration or lack of or sort of exposure to safety concerns. Whereby deinstitutionalization is a primary, clear that every child deserves a family, and in some ways underprepared also. But the global evidence is very clear, as well as the evidence from work that we have done in Jalna, in the family care arrangement lasts longer. Is we are really at a point where we have an opportunity before us where we can ensure that when we are moving as a country towards family-based care and institutionalization, it is not just about looking at where do will children live, but it is also about healing. It is also about helping children connect, helping children thrive within those families. So child protection and care is not just about shelter then, but is also about healing, is also about attachment, and is also about every child's right to thrive and to have access to safe family environment. So just to sort of build on to this context, I'm very excited now to take this conversation forward and announce our speakers for today. We are very grateful to have esteemed, experienced speakers with us who are each distinguished within their own fields. And with this and the work of mental health and psychosocial support to children, families, as well as community at large. So with this, I would like to invite our first speaker for the day, which is Mr. Deepak Tugnawat, who is the Director of Projects at Sangat's Bhopal Hub. Mr. Deepak brings with him a multidisciplinary academic background in social work, public health, and physiotherapy, along with 15 years of experience across clinical and public health settings. His core expertise lies in non-communicable disease management, with strong focus on mental health, digital interventions, implementation research, and he currently serves as a director of projects at Sangat's Bhopal Hub, where he leads several flagship interventions, which include serving as co-principal investigator on a 3-year NIHR fund grant, project mentor, and NIMH funded Samarth study, as well as an investigator for a Wellcome Trust funded study, SHARP. Mr. Deepak collaborates closely with National Mental Health Mission of Madhya Pradesh, as well as other esteemed institutions like Harvard Medical School, Beth Israel Deaconess Medical Center in the US, and many more. Mr. Deepak has also authored multiple papers and research documents across the globe within the space of mental health, as well as within the Indian context. Welcome, Mr. Deepak. The second speaker that we have for today is Mr. Shiva. Mr. Shiva Prakash Srinivasan, who is the HOD of Clinical Services and Training in the Department of Youth Mental Health at SCARF. Mr. Shiv Prakash Srinivasan is actively involved in training, empowering youth and their caregivers about mental health issues. He has an active interest in research and is currently working on developing safe spaces for youth within childcare institutions and in communities, and working with LGBTQI+ individuals. He's also affiliated with the IIT Madras in providing clinical care for students and faculty and creating well-being spaces for them. Also a part-time faculty at National Institute of Empowerment for Persons with Multiple Disabilities, where he offers mental health education to staff and students. He has published a number of articles, books, which have supported scholars to understand gender, youth psyche, and challenges. Welcome, Dr. Shiva. Really glad to have you on the panel. Our last speaker, our third speaker, last but not the least, is Mr. B.S. Nabi, who is a CWC member with Hyderabad and the state of Telangana. Mr. Nabi comes with a background with MSc Biochemistry and MS in Counseling Psychotherapy, and a BA CCY as well as ACY as an education, and is also a lecturer from around 6 years. He has worked with multiple not-for-profit organizations, counselors in childcare institutions for more than 11 years. He's a CWC member for the last 4 years and has a rich experience of more than a decade for handling and responding to various mental health and psychosocial support concerns. Welcome, Mr. Nabi, to the panel. So moving focus area for today. The first question that I would like to begin is by addressing to Mr. Deepak Tugnawat. So Sir, Sangat has worked across various systems of mental health by collaborating with various stakeholders. Can you, from your experience, shed some light on what does the mental health ecosystem look like for when it comes to children and families, and particularly those who might be in family-based alternative care arrangement and living in low-resource settings?
Thank you, Tanuja, for the introduction and for your question. And first of all, I would like to thank the Miracle Foundation and IACN for inviting me into this discussion, and I hope that at the end it will be a fantastic learning experience for me as well. So starting with the question about Sangat's experience working with the various stakeholders, I would say that the mental health ecosystem for children, families in low resource setting is often fragmented, and which is something which is underdeveloped. And then to specifically those who are in the family-based care. But at the one end, we see that the mental health issues are prominent nowadays, and specifically in low and middle income countries. And the primary reason being the shortage of trained mental health care professionals. So we see that We have limited number of psychiatrists and trained clinical psychologists or psychologists in India to provide the care. So the treatment gap is huge and wide. And even if we see from the 2015 and 16 National Mental Health Survey, which was done by NIMANS and AIMS Bhopal, we see that the treatment gap is around 90% in most of the cases. And this is the similar case even in the state of Madhya Pradesh, where 90% of the individuals do not receive any kind of care, even if they would like to seek the care. And this issue becomes worst in the rural areas, because even in the urban areas you will find the private practitioners and have the access, and the families are well versed to some extent to afford the mental health care. But in the rural areas, this is something which requires urgent attention. But at the same time, I would say that there are growing innovations which are hopeful, and those are something which gives hope that in coming years, the access to mental health will be improved. And here I would talk about the innovations in terms of the innovations which we tried at Sangat over last 28 years. So when we say we do not have the trained mental health care professionals like psychiatrists or clinical psychologists, then the best scalable, feasible, and affordable approach which we found is task sharing. And this is something which we started from our head office in Goa through our trial called Premium. Within the Premium trial, what we did, we started training the lay counselors. So we even didn't go to someone who has been trained in psychology or health or public health. Anyone who is 10 pass or 12 pass, we trained them, and then we saw whether the patient level outcomes are effective and comparable to the services those were delivered by trained mental health care professionals. And the results were fascinating, that yes, this is something which will work out. And then we have done number of experiments in different contexts and settings. And and then we then transitioned into the public healthcare system. And within the public healthcare system, then we started working with the specifically with the primary healthcare settings, so that we can integrate the mental health care services. So this is one of the innovation, that whenever we have a shortage which is there in our country, in our context, then we need to have alternative methodologies such as task sharing, through which we can provide mental health care access and services to those are in need, specifically to the children's and their families, and the vulnerable groups, and the marginalized populations. Because we see that most of these kids and their families are dependent on private clinics or NGOs, those who are working in this sector. But when it comes to the scalability and the reach, this is not going to happen until unless these gets integrated into the public system. And I'll talk more about the public system at a later stage. But innovation in terms of models such as task sharing, at the same time, the innovations at the level of the technology, so the digital innovations. We started telephonic screening and counseling support system at Sangat. Even during COVID-19 pandemic, we started free services across India in partnership with Sony Network, where we provided access to the psychosocial support to the individuals who were suffering. And this was open for anyone, whether it's for children, for adults, for geriatric population. Today we are talking about children and their families, specifically those are vulnerable. But sometime, and hopefully next time, we should also talk about the geriatric population, because that is also an area which requires urgent attention. And we have seen a lot of literature during the COVID-19 pandemic that they feel isolated even when they are living with their kids and families. And the last component in terms of the digital innovation, and just to add on, even the government has started numerous platforms, because confidentiality is a key when it comes to mental health care services, specifically with the vulnerable population, like children's and their families, and in the process of deinstitutionalization, then because the stigma is something which nobody would like to talk about the mental health within the community. Even the adults who are well educated doesn't consider common mental disorders as a disorder, because generally they speak like it's a stress and tension due to internal and external factors. Specifically acknowledge the external factors, but never talk about and acknowledge the internal processes and internal factors those affects, and then results into these common symptoms of the terminology which we use and people feel comfortable, like tension and stress. So again, here in terms of the digital innovations, as I said, even the Niman started Telemanas program. Based on our experience, we can say that yes, at least in Madhya Pradesh, this is working really well at the primary healthcare center level, where even a data coordinator or a data entry operator sits with a laptop and a camera phone, including a microphone, and then directly connects to an expert, and then the expert provides the required intervention, whether it's medication or a referral for psychosocial support at the district mental health program in the respective district. And the last point, to sum up, is when we say there are gaps, there are issues, there are challenges, but at the same time, yes, there are many opportunities. And we, if we all work together, and if we create a system which is interlinked, a system which works in coordination, a system which is reliable, a system which is accessible, and a system which is affordable for the vulnerable population, then yes, in coming years, we will definitely see a change. So for this particular question, I would sum up my response here. If any one of you have any questions, would like to ask anything, then please post your questions in the chat box, and I'll be happy to respond.
Thank you so much, sir, for sharing. I think sort of certain things that I'm picking away from this conversation is also the when you look at sort of limited resources, and in that context, looking at frontline functionaries and the role that each one of them can play, given with minimal amount of training in being able to identify is critical, but at the same time leveraging technology, leveraging remote tele-counseling or even digital screening processes to be able to identify early and ensure that appropriate treatment is made accessible is critical. And the third aspect that you really mentioned, which is very important, which is that language of mental health being accessible, which is very often sort of the consistent conversation that it is complicated and it is inaccessible and it is not something, or it's overwhelming and scary to the layman. So making sure that we are speaking the language that our beneficiaries or our community members are speaking, if it's tension, if it's tras, or if it's whatever in that local language, to using that and therefore sort of leveraging that local language as well as knowledge for focusing on mental well-being is critical. So just to sort of bring this in, and for some of our speakers, कि अगर हम बात करें जो सर कह रहे हैं उसके बारे में, तो दो तीन मुद्दे हैं जो सामने आते हैं. एक है कि मेंटल हेल्थ की ट्रीटमेंट की बात करते हैं तो लिमिटेड लोग हैं जो साइकाइट्रिस्ट या फिर ट्रेनर्स हैं, तो साइकाइट्रिस्ट या फिर परामर्शदाता है. तो उसी के साथ साथ जो लोग जो बच्चे के साथ एंगेज करते हैं या फिर एक फर्स्ट ऑर्डर में फैमिली के साथ एंगेज करते हैं, उनके साथ उनको ट्रेनिंग करना, कम से कम ट्रेनिंग देकर एक साइकोलॉजिकल फर्स्ट एड या फिर फर्स्ट रेस्पॉन्स देने के लिए इक्विप करना, और वो इक्विप करते हुए दूसरे साधनों का इस्तेमाल जैसे टेक्नोलॉजी, हेल्पलाइंस, ऑनलाइन डायग्नोसिस या ऑनलाइन कंसल्टेशंस, इसका इस्तेमाल करना. पर जो भाषा का इस्तेमाल हम करते हैं वो भी लोगों की रोजमर्रा के जीवन की भाषा अगर हो तो वो ज्यादा सही तरीके से इस विषय से जुड़ पाएंगे और अपने केयर के बारे में ज्यादा कनेक्ट हो पाएंगे. So with this, I would now like to sort of to our next speaker, which is Dr. Shiv Prakash. And a leader in building community mental health responses very early on. Sort of from your experience, psychosocial support for families within the existing child welfare or child protection systems.
Thank you so much for having me here, and I'm glad to be here to share some of my thoughts and some of the work that we've been doing. One thing that I would like to say is that I'm going to build up on what Mr. Deepak just talked about in terms of task sharing. And he was talking of task sharing and from the supply end of business in terms of mental health. What we also need to start thinking along in lines is when we are working with communities, you mentioned about the use of appropriate language, which is more engaging, which is more in touch with what the needs are. We might also have to think about the demand end of mental health needs. Now, many a time, whether when we are talking in terms of knowledge about mental health, there is clearly a lack of knowledge about mental health. People tend to conflate both mental health and mental illness. And as a psychiatrist, I take extreme unhappiness. I show extreme unhappiness in the fact that we are looked at only as problem solvers rather than looking at thinking about how do we grow, how do we flourish. And these are aspects of mental health which are not touched upon, which are not addressed. And that is clearly associated with all the stigma around mental health too. So that's an important thing that we want to try to progressively improve the supply side by trying to destigmatize it, by thinking about mental health as something which helps us grow rather than something that is just as an illness which is holding us back. This is especially something that we see in terms of when we work. So we have been working with childcare institutions in Tamil Nadu and in Orissa. We are working with the juvenile justice system. And what we are noticing is that knowledge about mental health itself is very low. So any sort of community intervention basically needs to start off from the point that all the people, whether it be the family members, whether it be the staff, whether it be the administrators, whether it be the entire juvenile justice system, needs to start thinking along the lines of, can we start knowing a little bit more about the mental health? Because psychosocial intervention invariably ends up being, within quotes, the first psycho intervention rather than the social intervention. And we need to destigmatize that. So education is something that we've been doing. The second part in terms of the demand is also when we work with young people. You talked about the UNCRC, and we know that right to participation is a core aspect, but engaging young people and educating them about their mental health is a core aspect of how do we get them to participate. So some of our work that we've been trying to do actively through our projects is trying to build capacity within the young people to actually take ownership of understanding what is mental health, rethink mental health as something which is a positive aspect, something about progress, development, and flourishing, and also learn the skills. So one of the key aspects that we have learned from all the people that we have worked with is clearly community mental health can't be done sitting in an AC room with the bright lights in a couch. It has to be at the level of what every single one of the partners who are visiting here are doing. They are actually working, engaging, and it has to be meaningful in the local language. So we've been using experiential methods in terms of activities, games, to actually develop the skills amongst young people to learn about mental health, to take care of their own mental health, emotional health, resilience, all those things. Now, one other key aspect that is missing in terms, so we talked about knowledge, we talked about stigma, we have to think about also the referral services. I'd like to say that as a part of the work that we've been doing, we've been linking with the district mental health program. But as Mr. Deepak very rightly said, for it's extremely hard to get mental health professionals, whether they are trained psychiatrists, psychologists, clinical psychologists, to work in the community. So some of the other innovations that we've been trying to work on is trying to train staff. So trying to develop a tiered system of care. So peer-to-peer care. So young people being able to provide support to each other, which I think is really important, because no matter how much we try, we have not lived the life that one young person in a foster care system or a child care system has lived. So being able to develop that sort of a peer-to-peer care is really important, because that will build the confidence of the person providing the support and make the person receiving the support actually feel heard no matter what. The next level of the tier should be the caregivers. So we are working with the caregivers, the administrators, and so on. And finally, referral can also be something that can be streamlined. So what we've been trying to do is link childcare institutions and provide them with the necessary templates for not only evaluating or referring children, but also maintaining records, so that once the child moves out of the care system into the foster care system or the alternate care system, or at times even reintegrating with their family, they carry their own medical records with them, so that their ongoing care is also maintained. So we need to think about this in terms of a continuum and not focus purely on the illness. Start from the wellness component, build the skills, enhance knowledge, in the process reduce stigma, identify people, and finally refer them for appropriate care. So I'll stop with that, and I'm happy to take more questions.
Thank you so much, Dr. Shiva, for your answer. And I think very beautifully you sort of summarized what you shared in terms of looking at mental health and not just illness, and the entire continuum of care, but also that to beginning with knowledge and making that accessible to people, to communities. But at the same time, when we're looking at building services, youth are active participants and are active owners in terms of active players in terms of facilitating their own mental health, and not just recipients of services. But you spoke about accessible, acceptable, non-clinical services, and which are more participative in nature, which help build well-being. And within that, by doing so by engaging with all stakeholders, if it is peers who have expertise by experience, if it's family members, if it's caregivers, then engaging with each one of those in the ecosystem. And the most important point that you also made is that continuity of care. Because that becomes a challenge often when a child is moving into a different family or into a different institution or into a different system. That accessibility of medical records certainly hinders the continuity of care. तो जो सर ने बात कही वो बस एक बार समराइज करते हुए संक्षेप में कि जो विषय या मुद्दा है जिसके बारे में हम बातचीत कर रहे हैं वो केवल बीमारी के बारे में बातचीत करने का नहीं है, बल्कि मानसिक स्वास्थ्य का मुद्दा है, और दोनों में अंतर है। इसके बारे में बातचीत करने के लिए हमें उसके बारे में जानकारी, और जानकारी जो कॉम्प्लिकेटेड नहीं है पर ऐसे शब्दों का इस्तेमाल करती है या इस तरीके की भाषा का इस्तेमाल करती है जो हमारे रोज के जीवन से जुड़ी हुई है। पर सबसे महत्वपूर्ण, अगर हम बच्चों की या युवकों की या किशोरों के लिए सेवाएं देने की बात कर रहे हैं, तो वो उनकी मेंटल हेल्थ की ओनरशिप किस तरीके से ले सकते हैं, उन्हें हम एक एक्टिव मेंबर इस प्रक्रिया में कैसे बना सकते हैं, जिससे कि हम एक पीयर टू पीयर सर्विसेज या फिर जो केयर गिवर्स है उनके द्वारा भी मेंटल हेल्थ का जो इम्पैक्ट है वो हम क्रिएट कर सकते हैं। तो ये पूरी प्रक्रिया में जो है वो बच्चे के पास अपने मेडिकल रिकॉर्ड्स या अपने ट्रीटमेंट या अपने हेल्थ केयर के बारे में अगर इंफॉर्मेशन एक्सेसिबल हो तो वो एक अपनी केयर भी जो है वो कंटिन्यू कर सकते हैं, नो मैटर वो किसी भी सिस्टम में है या किसी भी स्पेस में है उसके लिए। तो मैं अब आगे बढ़ना चाहूंगी. I would like to invite our third speaker. And Mr. Nabi, this question is for you. Just based on your experience, sir, and the cases that you have witnessed in your work as a CWC member, what kind of mental health needs do you see amongst children as well as caregivers who are sort of involved in foster care arrangements?
Thank you, ma'am. As per my experiences with the childcare institutions and even the juvenile children, as the other speakers have said, there is a lack of medical records. We can say that not the medical records or the basic information. The basic information lacks there, and the movement of the children from one CCI to other CCI, there is an issue. And whenever I come and have interaction with the children, the first problem is the children will be having emotional instability. Maybe due to the transformation of the children from one place to other place, or from their family to the CCIs, or from the CCIs to their family, reintegration. The first point is emotional instability, and it comes due to the fear. The child will be adjusted, he'll be in a circle where he feels comfortable. So we are moving the child from that place. So the fear starts. Once the fear starts, his emotions changes. Due to the fear, he gets anxiety. He becomes anxious and he shows all sorts of symptoms. Due to this, he may land up into stress. And whenever you come to stress, it will be in 3 stages. It may be the early one, middle, or late. If it is the first time the child shifting from the CCI to the family or from the family to CCI in the process of rehabilitation, he'll be more anxious where it is difficult to handle the child. If it is the second term or the third time, so the child will be habituated, he'll be coming out of the comfort zone, but he'll be having other fears. And due to this, once he develops the stress, he may not listen to our words, what we say, basically maybe for his own sake. And he may be having that separation anxiety disorder. We can say a sort of separation anxiety, because he will be separated from his comfort zone. And there will be a sort of other tantrums where he may run away, he may shout, he may beat, or he may use even the abusive language. These are the situations where the children face it. And normally the children where maybe in the CCIs or in their families, if they are basically in the families, they'll be comforted with the friends or the guardians. And as we have the discussion, the children are more into digital with the mobile. Maybe his father's mother or his friends, they are spending the more time with the mobile, where as the Dr. Shivaprakash sir has said, we need to go with his peers, maybe his friends, or the child who is comfortable with his family, and we need to train them. And we have got other issues, that is post-traumatic stress disorders. They will be there whenever they will be away from the mobile or the guardians or the friends or the CCIs. And the child may develop conduct disorders, that is the early first stage of conduct disorders or the second stage of conduct disorders. It starts with lying and nagging. For any simple issue, they'll start lying, which is not necessary. These are the issues where, and we need many more mental health professionals there, maybe trained, because we lack psychiatrists or psychologists, but we need many more trainers who may be trained as per the psychological guidelines, and these people should interact with the children. And basically in the metropolitan cities where there is more migration, we need more number of people who can approach to the children, maybe not in the terms of psychology, or they should be emotionally attached to the children. And once they start talking to them, child will reveal the things, what has happened to him. Once he starts revealing or the ice breaking has been done, there is a chance of retaining the children in a proper manner. Or we are talking in terms of child. So the child will be not showing all the above symptoms. That is emotional instability, fear, anxiety, stress, that separation, or basically elopement has been more due to this digital world. There is no interactions between the families, and even the caregivers who are in the institutions. There will be more number of children. They can't give one-to-one interaction with the child, every child. And even if the counselors are there, they are less when based on the children who are in the CCIs or the family. And whenever they come to the families, the family, both the mother and father goes for work. So there is less interaction between the children and the family or the guardian.
Thank you so much, sir. So what we understand is that the environment of instability, unpredictability, and the child moving into a newer environment or being in transition, those are certain aspects which serve as contributing factors, creating an experience of either emotional overwhelm, anxiety, low mood, and of course, in some cases, behavioral outbursts, which could sort of take a turn and develop into disorders like conduct disorders and so on. Certain challenges that you spoke about is also the disconnect within the family space or disconnect with somebody in whom the child is confiding. That becomes a big challenge, as well as the dependence on digital mediums like telephone or online life. That is also somewhere that further deepens the disconnection that the child might be experiencing. So what is required is also sort of that dedicated, consistent support for the child as well as the family, where the child has a space to share, open up, but also with somebody who's a consistent presence in their life. So that those are certain challenges that we do see come up within the foster care space. तो सर ने जो बात कही है उसे एक बार दोहराते हुए कि जब भी हम देखते हैं कि बच्चे ट्रांजिशन में होते हैं या फॉस्टर केयर या फैमिली बेस्ड केयर अरेंजमेंट में जाते हैं, तो कई बार वहां का वातावरण जो है वो उनके लिए एक बदलाव जो है वो अस्थिरता बनाता है। ये अस्थिरता उसी के साथ साथ एक अनफेमिलियरिटी बन जाती है कि एक नई जगह है जहां पर नए लोग हैं जिनके ऊपर मैं विश्वास करूं नहीं करूं ये बड़ा प्रश्न है। उसी के साथ साथ उनके जो पुराने जिंदगी में कई बार ऐसे हो सकता है कि आघात या फिर मुश्किल घटनाओं का उन्होंने सामना किया होगा, देखा होगा। इस वजह से जो है वो स्ट्रेस, एंजाइटी, इस तरीके के अनुभव आने लगते हैं। कुछ केसेस में जहां पर हम देखते हैं कि जहां पर जो उनका वर्तन है वो काफी प्रॉब्लमैटिक हो जाता है, या फिर रोना, चिल्लाना, या कभी कभी एक मानसिक बीमारी, बिहेवियरल डिसऑर्डर्स का रूप ले लेना, इस तरीके का भी एक समस्या दिखाई देती है। बच्चों को कई बार अपने दिल की बात रखने के लिए कोई एक स्थिर व्यक्ति नहीं होता है। इंस्टीट्यूशन में कोई एक व्यक्ति नहीं है, जैसे घर में घर के माता पिता दोनों मिलकर बच्चे का संगोपन करते हैं, उस तरीके से एक बच्चे को एक केयर गिवर या वैसा डेडिकेटेड सपोर्ट नहीं है। तो ये एक डेडिकेटेड सपोर्ट ना होना भी एक दिक्कत का कारण जो है वो बन जाता है। तो अभी इसी डिस्कशन को आगे ले जाते हुए मैं बस चेक करना चाहूंगी, और एक बार आगे जाने से पहले बस याद दिलाना चाहूंगी कि हमारे पास जो क्वेश्चन आंसर बॉक्स है वहां पर जरूर आपके जो सवाल है वो आप प्लेस करिए, और बिल्कुल हम कुछ सवाल लेने की कोशिश करेंगे। मैं देख रही हूँ चैट में भी कुछ कॉलीग्स ने सवाल डाले हुए हैं, तो हम वो नोट करके बिल्कुल ही उसके ऊपर डिस्कस करेंगे। अब आगे बढ़ते हुए मैं दोबारा से मिस्टर दीपक को बुलाना चाहूंगी। एंड सर, sort of just building on then, you worked closely with health missions, international partners, to integrate mental health into primary care. Can you share some lessons from this systems level integration that can be applied to strengthen mental health and psychosocial support interventions for vulnerable families and children, especially with the district child protection system?
Okay, thank you Tanuja again, and thank you for thank you for this very interesting webinar, because it was really nice to see what SCARF is doing and how the system is working in the southern part of the country. So when it comes to the integration, here I would like to take a different approach and try to simplify it as much as possible so that after the end of the webinar, all of our like 85 to 90 participants have it on their tips, like what we have done and how it could be done. So as I said, that we have started the using the task sharing approach. Like you need to train someone who is not a psychiatrist, not a psychologist, not a clinical psychologist, or have any training in mental health. Then you need to have a system in place, like how you will train them, on what you will train them, what they will do after the training, and whatever they do, whether it will sustain into the system or it will vanish as you get out of the project. Because like us, the organizations, we design interventions, we test those interventions, then we implement within the government setting, and as soon as our funding goes and we exit, the programs collapses. So to start with, when we say based on our learning, when we say that how we can design a system to integrate the mental health care services, including the psychosocial care, into the primary care setting, uh, including the vulnerable population, the child and their families, then the first item is generating awareness. How do we generate awareness? And whatever I'll talk about, I'll name the project. So if any one of you, those who are interested, please go visit our website, or you can go to Google Scholar or PubMed and read about these publications. So you can read about the project named Prime, read about Project Emerald, read about Project Essence, read about Project Anand, Project Sambhav, and Project Impress. And I'll be summing up all these six projects. So we will be able to better understand that how the integration can happen and last for long and get sustained by the healthcare system. So we knew, as rightly said by Dr. Shiva, that you need to first build confidence within the community so that they start talking about mental health within their own terminology, whichever way they feel comfortable. So in our context, they generally say stress, तनाव हो रहा है आजकल, चिंता होती है, ऐसा लगता है कि कोई मन नहीं लग रहा है, स्वभाव चिड़चिड़ा रहता है, कहीं मन नहीं लगता है, स्कूल जाने में मन नहीं लगता है, दोस्तों से बात करना अच्छा नहीं लगता है, हर समय फोन में रहता है। ये कुछ तरह के शब्द है जो मध्य प्रदेश के कंटेक्स्ट में यूज होता है. सो यू नीड टू जनरेट डिमांड. हाउ डू यू जनरेट डिमांड? यू नीड to design awareness material within the local context, the local language. How do you design? Even before you design, you need to understand their needs. What is their current understanding of health as a broader umbrella, and then mental health. So you need to sit with them. Sit with them means the community members in as per their age strata. So you need to conduct focus group discussions with the children's at their schools, whether the schools are primary schools, discussions with adolescents, then having discussions with the women's, the men's in the villages, including their local administrative setup, because it helps generate confidence within the community to sit with you and give you the time, such as having interaction with their sarpanch or the ward member or their local leader. And then you do this sort of exercise, understand what is their current understanding, what they need, why they are not going for any kind of these services, whether these are in person or remote. And then you design something to generate awareness. And once someone has awareness about a particular condition, then they definitely start seeking care. So, and then the second level come up. As soon as they become aware and they are confident that yes, this is something which requires an intervention or at least an interaction with someone who is trained, where do they go? And in Madhya Pradesh, there are 53 districts, but we have only 27 psychiatrists working in the at the level of DMHP. So even if they go to the district level, they won't get the kind of support which they should be receiving, especially in terms of the diagnosis, and then to especially for the severe mental disorders, because even as a psychologist is there, then the CMDs could be diagnosed, but for the SMDs, at least like you need a specialist to have interaction with you, and then make a proper diagnosis, and then the medications. So what we did, we started with the prime program where we said that yes, we know only 27 psychiatrists. Nobody is going at the district level, even if we generate the awareness. What do? We need a system below the district level or the civil hospital level. So we designed a model where we trained the doctors, the physicians, the MBBS or MD, the general physicians on WHO MHGAP protocol for 3 conditions: depression, anxiety, alcohol abuse disorders. And then we equipped them with the material whichever they needed, so that they are able to make the diagnosis and then refer at the district level or the higher tertiary care centers. Those are nearby to their serving capacity. At the same time, we trained the nurses on the screening of these disorders. And then we also trained nurses on brief psychosocial interventions, basic counseling. As soon as we did that, we saw that yes, it took time, but patients started asking about these services. They started talking about, okay, मुझे भी चिंता होती है, तनाव होती है, क्या मुझे दिखाना चाहिए, क्या मैं नर्स दीदी से पूछ लूँ, इस बारे में बात कर लूँ। फिर जब स्क्रीनिंग की बात आई तो हाँ, आप स्क्रीन कर लीजिए। फिर डॉक्टर के पास रेफरल हुआ, डायग्नोसिस कंफर्म होने लगे। देन द सेकंड इशू वाज मेडिकेशन. How do you ensure the medication? We started working with the NHM and the Directorate of Health Services to include the basic psychotropic medications availability at the community health center level. We were fortunate enough because the commissioner and the mission director were so helpful. Those got included in the EDL by then in 2013, and the access was given. Our team was the one who got the medications from the district store, and then they handed over at the PSC level so that the services could get started. As soon as we rolled it out, uh, when we started analyzing the data, we saw that yes, this is working, this is effective. Presented to the commissioner and the mission directors, they liked it, and then under our SOHM initiative, they requested us that could you please provide us the technical support? We would like to scale it up, and then this entire model got scaled up in the entire state, all the 53 districts of Madhya Pradesh, and this model was named as Mankaksh, a place, a chamber where you can talk about yourself, your feelings, and your emotions. Mankaksh. Even if you Google, you will be able to get more resources to read more in detail. So when we did this, then we found out that okay, there are only few people who go to the community health center level. Is there anything else which we need to do? Then the answer was yes, we need to do something at the community level and then at the primary healthcare level. Then through our Essence program, what we did, we trained ASHA workers. In Madhya Pradesh, within this program, we trained around 600 ASHA workers on brief psychosocial intervention called Healthy Activity Program, which was designed by Sangat. And then it was acknowledged by WHO. It's publicly available, open source. Google it. If you find it helpful, please use it. Again, as I said, HAP, Healthy Activity Program. So we trained around 1,600 ASHAs in 5 districts. Then through our another program called Empower Initiative, we scaled it up to 10 districts. So we trained ASHA workers on brief psychosocial intervention. And we, at the same time, we also trained them on the screening of depression. We started with depression. So the ASHA worker within the village, because they are the one who knows each and everyone within their village, within their community. So if anyone who is suffering or having any sign and symptoms, the ASHA worker could reach out to them, screen them, and then refer them to the PSC. And again at the PSC, we rolled out the Mankaksh model where we trained medical officers and we trained nurses and ANMs as well, because ANMs are the one who visits the villages.
Yeah.
And when we did that, the entire circle, the continuum of care was ensured. So now you have someone in the village who is having basic understanding about common mental disorders, have a tool to screen you, have the understanding for a proper referral mechanism where they are referring to the PSCs. At the PSCs, you have a medical officer who is trained upon, including the prescription of the psychotropic medications. In the PSC, you have a nurse and an ANM who will be able to screen you, document, refer, and even then do back referral where they do the follow-ups with the patients. And then from the PSCs, they can refer to CSC if it is needed. And when we worked with the NHM, we ensured that the DMHP psychiatrist visits these CSCs on weekly basis. So even if someone comes to the CSCs, the community health centers, on a weekly basis, there is a psychiatrist. If they would like to have any discussions about any complicated cases, then they have the opportunity to do so. And then at the district level, you already have Mankaksh. When we did that, the next step got followed up. I'll sum up in 2 more minutes. I'll sum up in 2 minutes. So when we started doing this, then we came to know that even the healthcare professionals started talking about these issues. As it was briefly talk by Dr. Shiva that and you, sorry, by you in your opening remarks, that even the care providers need to understand what is mental health. And then it was talked by Dr. Shiva that all the care providers, including those are like, for example, the protection officers or in the education department, they also need to understand what is mental health. But at the same time, they also need help and support for their own mental health and well-being. To do so, we got a request from NHSRC, which is the technical support unit of Ministry of Health, Government of India, that you are working with our Ashas. They are already overburdened, but you are not doing anything for them. This is when we started Anand program. And this is a program which is very, very promising. Our results will be out by January or February this year. Pilot study results are out. This is something where we started using the character strengths. And again, this is something which directly relates to the children's. Those are in need, those are vulnerable, those are marginalized. Because as said by our fellow panelist, Mr. Nabi, that the child goes through very difficult phase where they have uh, emotions which they can't express to anyone else. But at the same time, each and every individual, including us, we do have certain traits, in a different terminology, certain character strengths. So if there is someone, if you have a structured program where someone sits with you, assess your character strengths, talk about those character strengths, and then help you understand that how you could use your own character strengths to navigate within these difficult times and emotions which you can't handle in. And that's what we did with the ASHA workers. And then we again did with the ANMs, that how they can manage their own mental health. Finally, to sum up, the integration is possible, but it needs attention at 3 levels. One, the capacity. So when we say capacity building, the task sharing model is very efficient and effective, including it's cost effective. Please train ASHA workers, the Anganwadi workers through WCD, the protection officers, and the teachers who are interacting and the individuals who are managing these centers. The second level is the coordination. The referral is something which is very, very fragmented. Nobody knows where to go. Even if someone refers someone to X facility, even if the parents and the kid reaches there, there is nobody to provide care. And finally, you need to have policy, leadership, and financing support. Because as I said at the start, as soon as someone exits, program collapses, the strategies are not get implemented. So I'll stop here.
In the
I think
interest of time, I'll just come in over here, and I'll hold off the summary and I'll summarize for the entire second round of panel together. But we'll just move to the next question that we have for you, Mr. Nabi. Is essentially, can you share some examples where, in your experience, that effective mental health support was offered to strengthen family or to even facilitate alternative care arrangements? I think sort of what all of you are bringing in are very critical and very important learnings. But just would also like to sort of hear a little bit more about, as a CWC member, any experiences that you would have had where you can give an example of where, in your understanding, that effective mental health support was offered.
There was a family migrated to city, and both the parents were daily labor. They used to work, and father was alcoholic. Due to his alcoholism and the dispute between the wife and husband, they used to frequently change their houses. They had 3 children, 2 girls and 1 boy, and due to their disturbances, that is dispute, the child used to go away from the home and she used to stand up above their home. And the nearby area, there was a person who was a drug addict. He used to not go to school, and he was in sorts of all other things. And parents were not aware about the child, what their quarreling affects the child mind. So she used to go up frequently to the top of the home, and they were unaware. The child used to go, the person opposite, we can say that abuser, he used to talk to the child and say that parents do the same thing regularly, and I'll have a talk with you. Whenever you feel sad or emotionally disturbed, you can come up and talk to me. And she doesn't know his view of thinking about the child. Recently, he was smoking, and the child got habituated to smoke. And third time or the fourth time, the boy has kept drugs in the cigarette and has given to the child. Lack of that, she has taken, and she was abused sexually. As I'm a child welfare committee member, she was referred with 1098, the child line number. She has come to information of the district child protection officer. They have brought to Bharosa sheetings. We had a talk with the child. Then we said this, and the counselors in the Bharosa have made aware of the child. Then we had a talk with the child, and the child was sent for residential institution. And then we had a family counseling with the parents, and the parents were made aware that any dispute among them will disturb the child, because they were unaware, and they don't know about the counseling or the mental health or the psychosocial support. Even some people have stigma that if a child or a person goes and meets a psychologist or a psychiatrist, they talk that you are a psycho or you are mental. Still, there is a stigma. We need the awareness of the mental health. The child was counseled, the parents were counseled, and the parents were made aware that if there is any small change in the child's behavior from the day to day, you can go and consult any of the counselor in the Bharosa. This was the support for mental health. And even the child was also not aware that the person who was abused, they'll be giving the drugs in that, and they'll be using the children. In this, the child was sent back to the parents after repeated counselings. Everything was good, and suddenly one of a day again the father had full alcohol, came home, and they had a fight, and the child again has gone back to the top of the home. She met again the boy, and he has abused. This time what has happened, he has taken a video in the mobile, and the child came back. Again we made it, and with the help of the police and the counselor, we have deleted the videos. And the second time, we have focused on the parents, not the child, because the child is disturbed by the parents. both the family, mother and father, they were individually counseled by other counselors. We have referred them, and we have made aware that if they have any fight, it should not reflect on the child's mind. So after repeated counseling, we could bring the parents to a sort of a level, not completely that they started fighting in front of the child, but frequency was less. And the child was counseling was done, and the child was sent to a residential hostel, and there she was mingled with the friends, and she was fine with them. And the counselors have trained her not to reveal about her past to the other people, because in the friendship they may be fighting and quarreling. Again, the child may go into the past trauma. So she was also counseled, and still now repeatedly the child is doing fine. She is well with the family, but frequently we have asked our team, that is the district child protection officers, to have an evaluation with the child and repeatedly come and talk to the counselor and say whatever she has issues. Even the parents were also counseled, and the child is fine now.
Mm.
Why I have quoted this? Because mental health, we need awareness outside, and basically parents and the children. Due to these mobiles or the other drugs, many children have been abused. If they are not abused also, they are going to in a different manner. They may become antisocial events, or they may end up in as a child in conflict with the law also.
Mm.
As there is a view many in schools that there should be a psychologist in every school, but due to the lack of the trained professionals, there are not many people in the schools. If we can give awareness in the schools, we can stop maximum problems which may come up to the psychiatric level.
Mm.
This is one of the case where I thought of sharing with you.
Mm. Thank you so much, sir. I think highlighting sort of that creation of safe space, but also very often what we see as problem behaviors, which could be coping mechanisms that we may witness within the child, and they have to be understood like that. My last question I have for you, Dr. Shiva, is, given your experience and work within the space, and SCARF has been a pioneering organization in many of these spaces of mental health response, your engagement with young people and also within the child protection system. How can we sort of leverage, or from your experience of implementing these innovations, can you give us some insights about how can some of those learnings be leveraged for strengthening mental health support for children and families within the alternative care system?
I'd like to just quickly say that there is an element of the integrated care plan, the ICP, which is one of the key documents, which is amazingly well structured, and when applied appropriately, when it is used appropriately, it shows an amazing path for children to not only see them as they come in and address the concerns that CWC members such as Mr. Nabi and everybody observe, the DCPO observe, but also creates a pathway, because each step of that ICP is something which helps think about how are we going to get this child out into the community. And utilizing it as a tool is an extremely important method. A tool is only as good as the person who handles the tool. So making sure that the system is prepared to actually collect data and use it appropriately. So I know that there are a number of challenges. We've talked about demand, we've talked about supply, we've talked about the challenges, but I seriously think that we do have certain systems in place which can be built upon, and there is hope. I'd like to stop with that, and we should just work towards that. Thank you.
Yeah. Thank you so much, Dr. Shiva. So Just to summarize it all together, I think what we heard from Mr. Nabi also speak about how when children experience mental health concerns, there is a lot in the background for why those mental health concerns are experienced in that manner. And to respond to that also, there is what you were also highlighting, Dr. Shiva, is in terms of that there are certain mechanisms like the ICP, which is available. And folks have to be trained, or functionaries have to be trained to be able to use those tools effectively so that we can offer sensitive care. And bringing in what Mr. Deepak, you were also sharing here, is that building that multi-layered response from uh, building capacities of the ASHA workers or the on-ground functionaries and frontline respondents to sort of helping them building systemic level support for them, which can allow better adoption and a better environment of creating mental health ecosystem like this. And lastly, also not forgetting that while these are individuals who are offering mental health care, their own self-care and allocating appropriate resources to be able to build these ecosystem is something which is very critical. So I know we are really short on time, and we have received some very critical questions from our participants. So I'd like to at least take a few of those. If I may request our speakers to keep the answers brief, and we can try and then take as more questions if possible. So I think the first question that I have for you, Mr. Deepak, is that given the rise of digital tools, what role do you see for technology like teletherapy or even apps in expanding access? But at the same time, what leadership is required to ensure that these solutions are ethical, equitable, and really supportive to the person and the community accessing care?
Thank you. So when we talk about technology, so the question is very timely, because nowadays we see like a number of apps and chatbots are coming out, and they have their own unique way of collecting data, and the primary concern being that where this data gets stored. So for example, the work which we all do specifically for the internationally funded project, the primary concern being where the data will be stored. When we use technology, when we specifically use apps, then the server as per ICMR should be within India, and even as per the act which was discussed and passed last year in our parliament, which was about the digital security and safety. So this is something which is very critical to ensure the safety of the data, and but the vulnerable part is that how many apps do we need? Do we really need these many apps? Because the primary concern, even for a healthcare provider, if we talk about health, just go and ask your area's auxiliary nurse and midwife, the ANM, and a primary health center data entry operator. Like, how many apps do you use and operate? In MP, an ANM uses 12 different platform and apps. 12. Do we really need these many apps? Yes, technology is helpful, but without seamless integration, this is a burden on the providers, because we are having 12 apps, but at the same time, we are having 12 registers. So they have to do the maintain the entries into the registers as well, and then into the apps. But the struggle with the technology infrastructure, the internet, and the digital literacy. So even for the entry, even in Madhya Pradesh, even for the data entry onto these digital platforms, they need to hire someone externally to do the data entries. So technology is useful, but whether we are really using it in a way where it ease the life of the care providers, which is more pressing at the moment.
Yeah. Thank you so much for sharing. And I think sort of while we are talking about, we are also in a space where AI and technology is sort of in some spaces being looked at as a replacement for a human intervention or a mental health practitioner, and that is also sort of a ethical area to navigate or challenging area to navigate. I want to now move to Dr. Shiva, where we have a question for you, which is how does early adversities or trauma experiences from the person's, his or her family continue to affect mental health within the family or an institution context? And how do we sort of prevent, or what kind of preventive mechanisms can we engage in, keeping in mind this sort of an impact and a response to that?
It's a brilliant question, and I'd like to acknowledge the fact that mental health is influenced by so many factors. So the biological, psychological, and social factors. Our own study, the one which I quoted in our chat box, the JAM study, we found that even in childcare institutions, before children came into childcare institutions, 76% of them talked about experiencing neglect. But even after coming into childcare institutions, and this was highlighted earlier on, that children, more than 70% of the children did not have even one trusted adult. So it is not just a question of having experienced trauma outside, but trauma tends to continue within. And one way that we are really concerned about is traumatic experience sensitize you. So basically, your previous experiences prevent you from building those trusting relationships. So it becomes imperative on the system that we are able to create the necessary workforce who are more sensitive, more aware. Now, if we want to think about treatment, that is a completely separate issue. We can have sufficient number of sessions on that. But I think at least when we are looking at caregivers from within the system, we have to be doubly sensitive and triply careful when working with children who have experienced these experiences, because they are unable to build those relationships, and we have to be in a position to construct that environment. So it has huge implications on the long-term mental health of children, even though we tend to focus on the more immediate problems.
Thank you so much for sharing. I think it has been sort of extremely critical, and just to sort of bring what some of the points that have come in is one of the aspect being sort of moving away from the focus, which is treating symptoms, but to look at mental health holistically. At the same time, look at who are the key actors that we should engage with to be able to respond to mental health needs, because the ownership does not lie on one individual or one practitioner, because problems are not emanating also from that same space. And at the same time, leveraging the resources that we may already have to be able to strengthen them so that effective care can be offered. With this, I want to invite Kavita and Sonal to take the rest of the session forward. But my deep, deep gratitude for all the speakers for bringing in your learnings and your insights. I think they're really valuable for us. And it's really sort of, I think there is deep desire to want to hear more about it. But I hope this has sort of created a spark and will encourage folks to look up and explore more with the sort of rich knowledge that each of your respective organizations bring in. Over to you, Kavita.
Thank you, Ramita. I think Deepak ji has raises in. Deepak ji, do you want to add something, or it is by default?
So quickly, just to respond to one of the questions, which is there, what model of mental health support can be implemented in tribal
Very
residential
briefly,
schools?
Deepak ji.
So briefly, you could read about our initiative, which we started 4 months ago, mentor project. So until unless you train the teachers of the school, you won't be able to take it forward when it comes to the mental health support. So you could use a gatekeeper training program, WHO acknowledged program for training the teachers, and then you could use WHO's EASE program, which is a weekly session program for 8 weeks, where you can train the students in a batch of 15 to 20 over 8 weeks to learn more about mental health, how they can manage their own emotions and well-being, and then you can create a referral mechanisms within your context. For example, if you have RKSK program going on, then you have women counselors available at community health center level. So this sort of a model could be helpful.
Thank you, Deepakji, for answering this question. I know there are many more questions, and since we are running out of time and cannot continue further, but yeah, it has been a wonderful experience of having the amazing moderator and the panelists with us, and we've learned a lot about the policies and different kind of programs that Sangat staff has been running in the community, and the resources which has been shared by Deepakji and Dr. Shiva Prakash was very wonderful, and I think it will be very useful for the audience here. I know there are many questions, and with due permission of the speakers, we can share the contact numbers and organization contact numbers with all of you so that you can reach out to them, have more queries, have more discussions with them in the individual level. But on behalf of IECN and on behalf of the Miracle Foundation India, I would like to thank you from the bottom of my heart for the wonderful discussion, for sharing your experiences and learning and innovative practices with us today and with the audience. We will be having our next leadership dialogue on 27th November, which will be focusing more on economic resilience. As in the beginning, we shared that this leadership dialogue is also particularly focusing on convergence with allied departments. So, like today, we discussed about the mental health department and the mental health services. In the next series, we will be talking about how we can strengthen or provide or given support financially to the family so that the children do not come to the institution. So please do join us on 27. We will be sharing the recording of the session with everyone after that, and also a feedback form. Please do fill out the feedback form so that we know how we are doing and how useful this session has been for all of you. And we will also be sharing of FAQs and with all the participants. I mean, whatever question that we have received, we'll reach out to the speakers for brief answers to those questions also, and compile them all in an FAQ format and then share it with all of you. And also we'll be sharing the certificates to all the participants who have joined us today. So thank you so much again, and it's been wonderful. Thank you, Tanuja, for the wonderful moderation and making it into a both bilingual language, Hindi and English at the same time. And thank you, Dr. Shiva Prakash, thank you, Deepakji, and thank you, Mr. Navdeep, for being with us today. And to all the wonderful participants who have joined and made it a successful event again. Thank you, everyone, for joining.